I'm Celina Yong. I'm an associate editor at JACC, and I'm joined today by Dr. Ashkan Eftekhari from the Aalborg University Hospital in Denmark. Thank you so much for joining us, and congratulations on the OUT XI trial that will be published in JACC simultaneous with its presentation at EuroPCR.
Thank you very much for having me, and thank you for your reception and kind introduction.
I wonder if you could start by just telling us a little bit about each stent that you compared and the rationale for the study and what you found.
Yeah, sure. The OUT trials are very famous trial series that has been conducted for more than 20 years in Denmark. And the basic concept has been always to test two contemporary stents head-to-head in a non-inferiority design with target lesion failure as the primary endpoint. And this is the latest trial in the series, number 11. The two stents in question are BioMatrix Alpha, which has never been tested before in a randomized design before. And the reference stent was the combo stent, which was also evaluated in OUT X. And the results were published in the circulation a couple of years ago. And the two stents are distinct. There is a difference in their struct thickness, and most importantly for the combo stent, it has dual therapy properties. As you know, the OUT X showed that the combo stent was not non-inferior to the OUT stent, but we didn't know the results back then. So the concept is that these trials run consecutively. So we initiated the trial before we had the results of the OUT X. And because of that, we paused the trials, as we also will describe in the manuscript, to conduct the interim analysis to check for safety. And there was no signal of harm. So we continued the trial with a designated number of patients that we have predefined according to the power calculation. And the trial design is head-to-head all comers of all patients, all undergoing PCI. And it is the two stents against each other in one-to-one randomization. And it is a non-inferiority trial. As you know, the trial ran during the COVID era, so it took several years before it concluded. So that's also one distinction from this trial from the previous OUT trials, because the other ones usually were completed within 1-2 years maximum. So there has been some different circumstances with this trial, but we concluded the trial as planned, and the main result was that the alpha stent was non-inferior to the combo stent. But surprisingly, there was a strong signal of more stent thrombosis in the alpha arm, despite the fact that there was non-significant more cardiac death in the combo arm. And when you see the TLR curve and the MI curve, they're also increased in the alpha arm in the beginning. So that's kind of the main result to recap it very in short sentence.
Thank you for that comprehensive summary. You bring up an important point about the choice of DTS as a comparator and that the OUT trials for OUT X results were not out yet. I wonder, do you think that we can hypothesis generate about how the alpha stent may have compared to the Sirolimus-Eluting or Siro stent from OUT X, given that the trials had a lot of similarities, the same outcomes, they shared DTS or combo stent as a comparator. Do you think we can speculate about how those would compare?
That's a very good question, because obviously in the DTS is of course tainted by the OUT X results, and this trial raises more questions than it also answers, because it's somewhat people will ask, so should we use the alpha stent or not? And to answer your question, we are planning to conduct a meta-analysis of the two trials where we will pool the data, and then we will have a head-to-head comparison on individual patient level data. And as we are speaking now, our statistician is working on those data. So we will be happy to share that with you soon.
Amazing. We look forward to learning about that. To follow up on the issue of the stent thrombosis, that was almost unexpected because of the thinner struts in the alpha stent. Do you think you could
Exactly.
speak a little bit about what you think of those findings, what might have been driving those results?
It is, of course, before I answer that, very important to note that it is, of course, relatively small numbers. So although the result is statistically significant, it is a secondary endpoint. So we should be, of course, cautious to do hard interpretation of what and infer causal relationship with the alpha stent. But what we speculate, of course, it is speculation, it is that the thinner struts and there are more complex lesions in this trial than the previous trial, more calcified lesion, and perhaps the radial strength is not that good enough. Again, the Osiris stent is also very thin, and it has outperformed many stents, and it has very low stent thrombosis rate. So it is not because that all ultra thin stents are prone to stent thrombosis. There is no evidence of that at all, but that could be one explanation for it. And there is, of course, difference between the platforms. When the small diameters have a thinner strut than the bigger one. But again, when we reviewed the cases, it was the average diameter was 3.5 in the stent thrombosis population, which was the same as the rest of the population. So that's not an answer either. So of course, it can also be a play of chance, as we also state in the manuscript. But it is a clear finding, and it is what it is. And it has to be, of course, investigated further in our next meta-analysis.
I know that not all of them had intravascular imaging, but for those that did, was there anything that you were able to glean from that?
There were, for example, dissection at the edge in some cases, and some of them just occurred acutely. There was no cases related to DAPT. Of course, obviously, when you have acute stent thrombosis, you will speculate whether they have had insufficient DAPT. That was not the case. It was all of the cases were procedure related, and of course also stent related. And as you say, only 3 cases, as a few cases where we use intravascular imaging. So that's of course also a take-home message that always use intravascular imaging because it prevents severe outcome.
Thank you. The other question I had was about what was going on with the timing. You know, around the 4-month mark, the combo stent looked like it had increased TLR, a trend towards increased cardiac death. Do you think you could speak a little bit about what you think is happening over time?
We saw the same thing in the OUT XI, and one explanation could be the drug polymer is expires. So that's one explanation, because the drug polymer and the Biolimus drug is more has a more lipophilic compared to the DTS drug. So that's one plausible explanation that we see that trend, which is very clear, and you also see it in the cardiac death curve, which also diverges around 4 months. And we saw the same pattern in OUT XI, which drove the main result.
And there was one other thing that you mentioned in the manuscript about the enrollment during the pandemic and the interim suspension. Do you think that that affected anything? You know, can you describe sort of what that involved?
Yeah, that of course was delayed the trial, and when we resumed the trial, the pandemic was still running, and there was lockdown. So that of course slowed down the inclusion rate significantly, as it could have been as compared to normal circumstances. But as when you see the total event rate in the trial, it is the same as in the OUT XI. So it's not a different population. So it is actually a bit more complex. There are more type B2 and C lesions. So it's not. So it is representative of what the population we have. There is 2/3 of patients are ACS. So this it looks like our normal PCI population, but of course the pandemic and the interim analysis delayed the trial because of those circumstances.
Well, congratulations on still completing this incredible trial and getting the results you did. Are there any other details that you wanted to share about it that we haven't talked about yet?
No, I think we have discussed every aspect, and as I also told you, it is a very relevant question about the alpha stent versus the Osiris. So we will test that in our pooled analysis, and we will be very excited to see what the result is. And of course, we will have a pooled population of more 3,000 patients with combo stent. So that would also be the definitive study of the combo stent, whether or not it is stent that is eligible for the use of PCI.
That's very exciting. We look forward to seeing those results too. And congratulations again on the trial and your publication. Thanks
Thank
for
you
taking
very
the
much.
time.
Thank you for having me.